Welcome to the 2017 EMS Protocol Update for EMT, Advanced EMT, and Paramedics. For this training we'll be discussing non-invasive positive pressure ventilation, NIPPV, along with the differences between the two most common pre-hospital options. These devices can also be considered for use during inter-facility transport. BiPAP, bilevel positive airway pressure, versus CPAP, continuous positive airway pressure. While this presentation will give a brief overview, it will be the responsibility of each provider to fully understand the indications and contraindications for the use of these devices. Please do not use this as your only source of education. It should be noted that non-invasive positive pressure ventilation is now a EMT basic level procedure. NIPPV and CPAP is now included in the following protocols: Airway Respiratory 1 Adult Airway, Airway Respiratory 4 Adult COPD, Asthma, and Respiratory Distress, Adult Cardiac 5 Congestive Heart Failure and Pulmonary Edema, Toxin Environmental 3 Drowning. CPAP provides a continuous pressure of oxygen to the alveoli. This pressure prevents alveolar collapse and thus may open up previously closed alveoli, alveolar recruitment. However, the patient has to overcome this pressure during exhalation. While CPAP provides a resource for rescue efforts, the patient may have difficulty in working to overcome the pressure this device provides. You can see in the example images in the lower right hand of the screen, normal alveoli versus collapsed alveoli. This treatment should not be considered when the systolic blood pressure is less than 100 mm of mercury. Should the patient become hypotensive, remove CPAP and treat patient according to proper protocol. BiPAP provides CPAP, but senses and adjusts the oxygen pressure to the patient's breathing cycle. The oxygen pressure increases during inhalation to provide maximal alveolar recruitment. During exhalation, the pressure decreases to ease breathing while keeping alveoli open with its adjustable CPAP function. In essence, BiPAP provides greater control for acute respiratory distress and may provide better gas exchange to optimize cardiopulmonary performance. BiPAP provides better outcomes in patients with COPD when compared to standard medical treatment of oxygen, nebulizer therapy, and steroids. CPAP may be better for acute cardiogenic pulmonary edema. However, studies have not shown a clear or consistent advantage to BiPAP over CPAP when looking at clinically significant outcomes such as decreased mortality, need for intubation, ICU admission, and length of hospital stay. After looking at the evidence of BiPAP against CPAP, the only advantage BiPAP appears to provide is a decreased time to resolution of respiratory symptoms, vital signs, and improvement of laboratory values. However, keep in mind that this difference doesn't occur until late in the treatment course. While this shouldn't affect most EMS systems with short transport times, some rural EMS systems may take the long-term effects of BiPAP into consideration given their longer transport times. Otherwise, current evidence demonstrates minimal benefit to BiPAP over CPAP. It is the responsibility of each department along with each EMS provider to be proficient in the use of these devices. If you have questions about this presentation or any other information related to the protocol update, you should direct them to your training officer for clarification.